These are my disclosures. So what I thought I would show you guys is that we've done a couple of cases of a novel left ventricular volume reduction therapy. This is being tested by BioVentrix. And the concept is that in patients with ischemic cardiomyopathy and anterolateral scar, that via a lateral thoracotomy and via right IJ access into the RV, we're going to place kind of an RV pledget and a LV pledget, and we're going to bring scar to scar together to basically exclude the aneurysm and to reduce the LV volume. And here's an animation of going in through the right IJ, going in through the left thoracotomy, creating a rail, snaring the wire, creating a rail, and then advancing an RV anchor from the IJ and LV anchor from the thoracotomy. And it's easy, it just takes 30 seconds, just like that. The idea is to, restore LV size, volume, shape, and the efficiency of the LV contraction. Obviously, it's not a sternotomy, but it is a thoracotomy, but hopefully it's a reduced surgical risk procedure. And then, the real question is whether this will improve clinical outcomes, of course. And so, the idea is to place not just one anchor, but several anchors across the aneurysm to exclude the entire aneurysm. And it's a kind of a case-by-case thing, but this is what it would look like from the outside of the heart looking in. Some preliminary data from Europe have shown decrease in LV systolic volumes following the procedure, decrease in LV diastolic volumes following the procedure, improvements in LV ejection fraction, and some improvements in quality of life. This is the lower numbers on the Minnesota Living with Heart Failure questionnaire associated with better quality of life. So. So in terms of earlier results, this system is minimally invasive. It does appear safe and effective, reduces LV volumes, improves LV ejection fraction, and appears to improve symptom status and quality of life. The US IDE trial is called Alive HF, and that's what we've participated in. There's a lot of European experience, but I think we're just getting started in the US here. So. I'll show you our second case, which we just did a few weeks ago. 73-year-old gentleman with a late presentation LAD infarct in 2011, EF of 23%, severe LV dilatation, large apical aneurysm, 54% of the myocardium infarcted based on PET-CT, NYHA class 2 to 3 CHF symptoms prior to his infarct in 2011. He was an avid runner, so huge change in his symptom status after this infarct. His baseline echo, no question about this, anterior apical aneurysm. It's important to understand the geometry of the heart and how much RV apex you have to work with in relation to the LV aneurysm. And here, you see that this part of the septum is all functioning myocardium, so we don't want to anchor anything to that functioning myocardium. We really only want to anchor out here, in terms of the RV anchor anyway, we only want to anchor out here where the septum is akinetic. And so that, every case will be different in terms of geometry and how you're going to place those anchors is the point. If you look here at the CT assessment, here again is the RV, and here is kind of the transition between functioning myocardium in the septum and this aneurysmal segment. And you can see there's very little RV apex out here. So our strategy was to place only one RV anchor, and that would be the first anchor. And so you'd have an RV anchor here, and then the first LV anchor here, and you'd bring this together, and then you can put a series of LV to LV anchors in to exclude the rest of the aneurysm. And again, every case is going to be a little different. So, in that animation, you saw that a wire was snared in the RVOT, and we did that in our first case. We had a lot of ventricular tachycardia from the snare, and we also had difficulty directing, when you're kind of coming out here from the lateral LV wall, and you're aiming for the RV apex, then trying to, turn that wire up into the RVOT also gave us difficulty. So the combination of those two things, was difficult in the first case. So we decided in this case that we try to snare the wire in the RV apex. And so we, obviously we have a large sheath here in the IJ. We advance a snare to the RV apex. And then we come in from the thoracotomy, cross from scar to scar, and we snare the wire and create this rail. And then through the IJ sheath, now we're advancing this RV anchor, which is still, snared on the LV side. I'll just show that again. So we, kind of as we're advancing from the RV side, we're, pulling gently from the LV side. And now we've got that. There's kind of a lever to flip that anchor up right there, and now hopefully that's adjacent to the RV septum. And then once we kind of cinch those together, then we remove that wire, and you've got your first set of anchors. And then 3 LV to LV anchors were placed, all from the thoracotomy side. And that's just done with a needle and 2 anchors. It is a pretty slick system. This is what it looks like at the end with the multiple anchors from the thoracotomy, and here's the post-procedure echo. So, in retrospect, maybe one more LV to LV anchor here would have, been the final, therapy to exclude the apical segment of that aneurysm. But the LV volumes were reduced by echo, and so, we concluded the procedure at this point. The patient had an initial good recovery, but after starting heparin, which is part of the protocol, he did have a hemothorax and required a chest tube. He then went home and had a syncopal episode, broke 2 bones in his foot. That's not one of the secondary endpoints, so that's not going to. So that'll be fine. They're not going to count that. His carvedilol was switched to metoprolol. His 1-month echo showed a 28% reduction in his LV volumes and an improvement in his EF from 25 to 35. But the impact on his functional status will need to be assessed after his foot heals because he's a little immobile right now. So that's my novel technique.
Great case. So while Richard comes up, so I have a quick question or 2 questions. One is. In the experience so far, is there any concerns about pull-throughs, about anchors kind of pulling through or dehiscing?
No, we haven't had any problems with that. So, the anchor really, it's really only a needle puncture, right? When you go from scar to scar, and then it is fibrosed. So, I haven't been on the LV side, but the surgeons tell us you really have to push through that scar, to get through it. And so then you only have a needle puncture and really kind of a large anchor. So I don't think a pull-through would be an issue.
And then the final question was about anticoagulation. You've taken a large surface area, and especially in that last apical, almost like a little apical nipple almost. I mean, is there a risk of increased thrombus in that?
Yeah, I think so. And, and this is, the heparin is part of the protocol in anticoagulation. And, if any of you were involved in the parachute trial, which we also did, unfortunately, I think that the anticoagulation was one of the problems. We saw nice reductions in LV volume. We had, this is anecdotal, of course, we had patients who felt better as a result. We had a lot of bleeding complications, including, one was a major hemorrhagic stroke. And so I think that could be one of the Achilles heels of this.
Great presentation.
Thanks.
All right, so I've been looking forward to this one. So Dr. Richard Bay is going to give us a talk of, I didn't know my probe could do this.
Thank you, and thank you, Paul, for the clickbait title. So I'm just going to show a quick case. A lot of the procedures we do have kind of prescribed images and standardized views, but certainly working with Paul, sometimes some of the things we do, you got to kind of work on the fly. I actually had a different case, but I don't think the company's ready to reveal the device, so I got an alternative one here. This is my disclosure. So this is the only text slide. 56-year-old woman who had a history of staph endocarditis. She had an AVR homograph, tricuspid debridement, VSD repair elsewhere, but developed a residual LV to RA shunt with a big QPQS. Ascites, dyspnea, didn't want to reoperate, and referred to Paul to consider percutaneous options. And Paul can put a plug anywhere. So from the imaging viewpoint, it's pretty obvious there's a big LVOT to RA shunt here. Not so well seen on the standard long axis view, and quite a bit of gradient across the shunt. So big hole should be no problem. So the initial plan was to just start to cross from the right side with it, from the RA into the LVOT with a wire, but it just didn't seem to want to go. I mean, it looks like a big hole, but didn't want to get across. So while Paul was switching out the wires, I decided to say, oh, well, let me see what else I can do. So this ended up being the key view. This is kind of a modified transgastric view here, and I labeled it for the non-echo people, where you can see the LVOT, the aortic valve, and the defect. And you can see that the defect is actually kind of like it's a windsock, but it actually opens and closes. If I could get that to play, unfortunately. But, and that's probably why the wire wouldn't go across, because the flap closes and the cardiac cycle and the wire didn't go out, want to go across. So in kind of a smart alecky way, I think I said something like, you know, I'm just a simple echo guy, but it looks like if you put a right coronary catheter across the aortic valve and just pulled it back, it'd go right across. And the appropriate response would be...
He is the most important person in the room. There's no question about that.
The appropriate response from Paul would be, stay in your lane, bro. But Paul's too nice to do that. So in fact, that's ended up what we did. Here we go. So here you see the catheter coming across, and a wire goes across. You couldn't really see it in this view, but in the X-plane view, you see it coming out here into the RA. So great, we got a wire across. Paul creates a rail, snares that, and then the plan is to deploy the LVOT side of the disc first. So the catheter's advanced. Here it goes across the defect and up into the ascending aorta. But with the release of the distal part of the disc, we wanted to be in that small space right below the aortic valve, but not pull it back across the defect. And you see it's not well visualized here in this long axis view. So get a little creative, and here on 3D, you can see from the RA into the LVOT and out the aortic valve. I flip it around, here's from the RA side, pull the catheter back a little bit just below the aortic valve, and here it's in that space between the aortic valve and the LVOT, and here's the distal disc. So here's the distal disc, and then the proximal disc comes out, and great. Are we done? No, I mean, the concern is we're pretty close to the aortic valve and the tricuspid valve. Are we creating any leaflet impingement? So that's a little hard to see in these views. It looks like it's probably okay, but then, you know, get creative again, and this is more of a deep transgastric. Here you can see the septal leaflet insertion. You can see that this disc isn't impinging. And it's a little hard to see, but you can see the aortic valve looks like it's fine too. There's no stenosis or regurgitation. So, you know, if a standard view is not working, try non-standard alternative views. In this case, transgastric views, LVOT 3D views were instrumental. Try to get a little creative. Thanks.